Hello. Today I say you about side effect of different drugs, classification of side effect, and drug allergy. Uh, you can, after our lecture, you can um, have answer on several tests and uh, cases for control. And so what is the side effect of drugs? Nature is neutral. For example, it has no intentions towards humans, so it's often unfavorable to them. It's humans in their desire to avoid suffering and disease who decide that some of the biological effects of drugs, therapeutic and other undesirable adverse effect. In addition to this arbitrary division, which has no fundamental biological basis, numerous non-drug factors promote or even cause unwanted effects. Because of the variety of these factors, attempts to make a simple account of the unwanted effects of drug must be imperfect. There is general agreement that drugs prescribed for disease themselves the cause of serious amounts of disease, ranging from mere inconvenience to permanent disability and disease. It's not enough to measure the incidence of adverse reaction to drug, the nature and the severity. Also, accurate that obviously useful is necessary to take or to try to take into account which effect are avoidable. As there can be no hope of eliminating all adverse effects of drug, it's necessary to evaluate patterns of adverse reaction against one another. One drug may frequently cause minor ill effects, but pose no threat to life. So patients do not like it and may take it irregularly to their one long-term harm. Another drug may be pleasant to take, so that patient take it consistently with benefit, but on rare occasion it may kill someone. It's not obvious which drug is to be preferred. Some patients, for example, those with a history of allergy or previous reaction to drug, up to 4 times more likely to have another adverse reaction, so that the incidence does not fall evenly. It's also useful to discover the causes of adverse reaction. For example, individuals who like certain enzymes. For use of such knowledge can render avoidable what are at present unavoidable reaction. More skillful prescribing will reduce avoidable adverse effects, and this means that doctors, among all the other claims on the time, must find time better to understand drug as well as understanding patient and this disease. Many unwanted effects of drug medically trivial, and in order to avoid inflating the figures of drug-induced disease, it's convenient to retain the widely used term side effects for minor reaction that occur at normal therapeutic doses, and there are predictable and usually dose-related. The term adverse drug reaction should be confined to harmful or seriously unpleasant effects occurring at doses intended for therapeutic effect, and which call for reducing on dose or withdrawal of the drug, and for a case hazard from future administration. Its effect of this order there are of importance in evaluating drug-induced disease in the community. The term adverse reaction is almost synonymous with adverse effect, except that an effect related to the drug and reaction to the patient. Both terms should be distinguished from adverse event, which in adverse happening that occurs during exposure to a drug without any assumption being made about its case. Toxicity implies a direct action of the drug, often at high dose damaging cells. For example, liver damage from paracetamol overdose, at cranial nerve damage from gentamicin. All drugs for a practical purpose are toxic in overdose, and overdose can be absolute or relative. In the latter case, ordinary dose may be administered but may be toxic due to underlying abnormality in the patient. For example, disease of the kidney, mutagenicity, cancerogenicity, teratogenicity, special cases of toxicity. Secondary effect are the indirect consequences of primary drug action. Example, vitamin deficiency or opportunistic infection in patient whose normal bowel flora has been altered by antimicrobial diuretic-induced hypokalemia causing digoxin toxicity. Intolerance means a low threshold to the normal pharmacodynamic action of drug. Individuals vary greatly in this susceptibility to drug, so that one extreme of the normal distribution could be intolerant of the drugs. So as the other tolerant idiosyncrasy implies an inherent qualitative abnormal reaction to a drug, usually due to genetic abnormality, for example, porphyria. When unexpected event for which there is no obvious cause occurs in a patient already taken a drug, the possibility that this drug attributable must always be considered. Distinction between natural progressive disease and drug-induced deterioration is particularly challenging. For example, sodium in antacid formulation may aggravate cardiac failure. Tricyclic antidepressants may provoke epileptic spasms, and aspirin may cause bronch. The following elements useful in attributing the case of adverse event to a drug. It's first the time sequence in relation to taking the drug. The majority of reaction develops soon after exposure. Anaphylactic reaction within minutes or minute 1 or 2 hours, and hypersensitivity reaction within weeks may readily suggest association, but delayed effects such as carcinogenesis or tardive dyskinesia after years or even disorders present more difficulty. Second, the effect of withdrawing or reintroducing the drug. Most reactions subside when the drug is discontinued unless an autoimmune reaction established when effects persist. Planned re-exposing and patient to a drug is rarely indicated unless treatment with is essential and there is no reliable alternative. And last, this type, this of course invites questions about consistency with established pharmacology and toxicology of the drug or related substances, chospasm in some asthmatics. And you can see several slides. White, who have these risks? Risks factors. Okay, caution about 80% of well people not taking any drug, admit questioning to symptoms, often several such commonly experienced as less as adverse reaction to drug. Administration of placebo intensifies or diminishes their symptoms. So many symptoms or minor symptoms may be wrongly attributed to drug. Similarly, minor and the possibility to transcend abnormality in laboratory results, for example, liver function tests occur in apparently healthy people. Okay, next slide. According to Syncity, and how long time can be wait after using drug? What is this reaction? Clinical classification. It can be general reaction, damage to the skin, or only mucous membranes, damage to respiratory organs, or only on heart damage, and international classification. We have several types of reaction. Type A, primary toxic reaction or drug overdose. Side effect, actually. It's maybe only secondary effect, and we wait this reaction. Type B, individual intolerance. It's all allergic reaction, idiosyncrasia, hypersensitivity, pseudo-allergic reaction. Type C, reaction with long-term use of drugs. Type D, delayed effects. Type E, withdrawal reaction. It's stop use drug and patient has side effect. And last, type F, patient haven't any effect after using drug. Anaphylactic reaction to the administration of a local anesthetic belong to which type of adverse reaction? What do you think? It's allergic reaction. It's type B. Etiopathogenetic classification of side effect. Toxic effects. Effects due to the pharmacological properties of drug. Includes superinfection, bacterial Third, true allergic reaction, all type allergic reaction. All allergic reaction consist large part of side effect of drugs. And you can see all the drugs write different results up to 20% by to 70% of all side effects. Phases of allergic reaction. Sensitization, it can be several days. Resolution, it can be a few seconds up to 2 days. And desensitization. And a risk of developing drug allergy. Polypharmacia, when our patient to use 5 and more drugs on one time. Long-term use of drugs, heredity, and associated disease. Allergic reaction to drug as a result of the interaction of drug or metabolite sometimes non-drug element in the formulation with patient and disease and subsequent re-exposure. Lack of previous exposure is not the same as lack of history of previous exposure and first dose reaction. Among the most dramatic, exposure is not necessarily medical. For example, penicillins may occur in dairy products following treatment of mastitis in cows, and penicillin antibodies are commonly present in those who never haven't received the drug. Immune responses to drugs may be harmful in varying degrees. It's allergy or harmless. The fact that antibodies produce it doesn't mean a patient will necessarily respond to re-exposure with clinical manifestation. And type 1 reaction. Immediate or anaphylactic type. The drug causes formation of T-sensitive immunoglobulin E antibodies that are fixed to mast cells or leukocytes. On subsequent administration, the allergen react with antibodies activating but not damaging the cell to which they are fixed and causing release of pharmacologically active substance, for example, histamine, leukotrienes, prostaglandins, platelet activating factors, and causing effects such as urticaria, anaphylactic shock, asthma. Allergy develop within minutes and last for 1 or 2 hours. It may, of course, be fatal. While macromolecules, protein, peptides, dextran polysaccharides can act as complete antigens, most drugs, simple chemical, and act as incomplete antigen or haptens, which become complete antigen in combination with a body protein. The chief target organs of drug allergy are the skin, respiratory tract, gastrointestinal tract, blood, and blood vessels. Allergic reaction in general may be classified according to 4 types of hypersensitivity, and drugs can elicit a reaction of all types. Type 2 reaction, antibody depend, the drug or metabolite combines with a protein in the body so that the body no longer recognizes the protein as self, treats it as foreign protein and forms antibody. It's immunoglobulin G, immunoglobulin M, that combine with the antigen and activate complement, which damages cells. For example, penicillin or methyl dopa induced hemolytic anemia. Next side effect, teratogenicity, cancerogenic side effect. Side effect caused by the pharmacological properties of drug, dysbacteriosis, superinfection, bacterialysis under using antibacterial drug, pseudoallergic reaction, idiosyncrasy. And next, type 3 reaction, immune complex mediated type, antigen and antibody form large complexes and activate complement. Small blood vessels damaged or blocked. Leukocytes attracted to the site of reaction engulf the immune complexes and release pharmacologically active substances, including lysosomal enzymes, starting an inflammatory process. This reaction includes serum sickness, glomerulonephritis, vasculitis, pulmonary disease. Next, type 4 reaction, lymphocyte-mediated type, antigen-specific receptors develop on T lymphocytes. Subsequent administration leads to local T-cell allergic reaction, for example, contact dermatitis. Practicalities of detecting rare adverse reaction. For action with no background incidence, the number of patients required to give a good chance of detecting the effect, assuming the 3 events required before any regulatory or other actions should be taken. It shows the large numbers of patients that must be monitored to detect even a relatively high incidence adverse effect. The problem can be many orders of magnitude worse if the adverse reaction closely resemble spontaneous disease with a background incidence in the population. And prognosis for many people, they will be healthy. And small part, lethal output. Next side effect, drug addiction. It can be mental or physical addiction. It's when patients stop using drug, and after that, the next time a patient has a side effect. Mental dependence syndromes. For example, after stopping narcotics, and syndrome of physical dependence, narcotics again, and you can see what is substance for this side effect. Diagnosis of drug allergy. This still depends largely on clinical criteria, history, type of reaction, response to withdrawal, and systemic re-challenge. Simple patch skin testing is naturally most useful in diagnostic contact dermatitis, but it's unreliable for other allergies. Skin prick tests, helpful in specialist hands for diagnosis immunoglobulin E dependent drug reaction, notably due to penicillin, cephalosporin, muscle relaxant, and more other drugs. They can cause anaphylactic shock. False positive results occur. Development of reliable in vitro predictive tests, for example, employing serum or lymphocytes, matter of considerable importance, not merely to remove hazard, but also to avoid depriving patient of drug that may be useful. Direction of drug-specific circulation immunoglobulin E antibodies by the radioallergy sorbent test is best developed for many drugs and other allergens. Drug allergy, once it has occurred, is not necessarily permanent. For example, less than 50% of patients given a history of allergy to penicillin have reaction if it's given again, but rechangeling is best avoided if possible. Once patients become allergic to a drug, it's better that they should never again receive it. Desensitization may be considered where a patient has suffered an immunoglobulin E mediated reaction to penicillin and required the drug for serious infection. For example, meningitis or endocarditis. Such people can be desensitized by giving very small amounts of allergen, with then gradually increased usually every few hours until a normal dose is tolerated. The procedure may necessitate cover with corticosteroid and beta adrenergic receptors agonists, both of which inhibit mediator synthesis and release. And then H1 receptor antihistamine may be added if adverse reaction occurs. A full kit for treating anaphylactic shock should be at hand. Desensitization may also be carried out for other antimicrobial. For example, anti-tuberculose drugs. Mechanism underlying Desensitization may involve the production by the patient of blocking antibodies that compete successfully for the allergen, but both combination with its inner cause inner causes or the threshold of cells to the triggering antibodies may be raised. Sometimes allergy is to ingredient of the preparation, other that the essential drug, and merely changing the preparation is sufficient. Input sometimes responsible and purified penicillins and insulins reduce the incidence of reaction. Prevention of allergic reaction. Prevention is important because those reactions are unpleasant and may be fatal. It provides good reaction for taking a drug history. Patients should always be told if there's reaction to believe they're allergic to a drug. When looking for alternative drug to avoid an adverse reaction, it's important not to select one from the some chemical group, as may inadvertently occur because the proprietary name gives no indication of the nature of drug. This is another good reason for using the non-proprietary genetic names, matter of course. And pseudo-allergic reaction. This effect mimicking type 1 reaction above, called anaphylactoid, there occur with aspirin and other non-steroidal anti-inflammatory drugs, and with N-acetylcysteine, corticotropin, direct histamine release, intravenous anesthetics, and variety of other drugs given intravenously. It's can be dextran, radiographic contrast, morphine, tubacurarine, and inhaled chromoglicat. Several cases treated as for true allergic anaphylactic shock, from which at the time there are not distinguishable. Type 2 reaction mimicked by the hemolysis induced by drug. Some anti-malaria drugs, sulfonilamides, and food, broad beans, in subjects with inherited abnormalities of erythrocyte enzymes, hemoglobin, and type 3 reaction mimicked by nitrofurantoin and penicillamine, lupus erythematosus due to drug. It can be procainamide, for example, maybe pseudo-allergic reaction. Transient reaction to intravenous injection are fairly common, resulting in hypotension, renal pain, fever, or rigors, especially if the injection is very, very rapid. So the majority of adverse events occur within days or weeks after drug is administered. Some reactions develop only after months of years of exposure. In general, pharmacovigilance programs reveal such effect. Once recognized, they demand careful monitoring during chronic drug therapy of others occurrence may carry serious consequence for the patient, and the non-vigilant doctor medically description of such reaction appear with accounts of relevant drug. Some example are given. Toxic cataract can be due to chloroquine and related drugs, adrenal steroids. It can be systemic and topical. Corneal opacities occur with phenothiazine and chloroquine. Retinal injury developed with pyridazine, chloroquine, indomethacin, and visual field defect with vigabatrin. Next, nervous system. Tardive dyskinesias occur with neuroleptics, polyneuritis with metronidazole, optic neuritis with ethambutol. Lungs. Amiodarone may cause pulmonary fibrosis. Sulfasalazine is associated with fibrosing alveolitis. Kidney. Gall salts may cause nephropathy. See also analgesic nephropathy. Liver. Methotrexate may cause liver damage and hepatic fibrosis. Amiodarone may induce steatohepatitis, fatty liver. And cancerogenesis. Mechanism of cancerogenesis are complex. Prediction from animal tests is uncertain, and causal attribution in human has finally to be based on epidemiological studies. The principal mechanism, there are alteration of DNA, genotoxicity, mutagenicity, many chemical or their metabolites act by causing mutation, activation, oncogenesis. So, substances that are used medicine include griseofulvin, alkylating, cytotoxics, leukemias, and lymphomas, the most common malignantification. And next, immunosuppression. Malignancies develop in immunosuppression patients, for example, after organ transplantation and cancer chemotherapy. There is high incidence of lymphoid neoplasm. Melphalan, tiotepa present particular high relative risk. There are of immunosuppression, for example, rheumatoid arthritis, increase the incidence of neoplasms. And next, hormonal. Long-term use of estrogen replacement in postmenopausal women induces endometrial cancer. Combined estrogen, progesterone, oral contraceptives may both suppress and enhance cancers. Diethylstilbestrol caused vaginal adenosis and cancer in the offspring of mothers who took it during pregnancy in the hope of prevention miscarriage. Controlled therapeutic trials were not done, and there was no valid evidence of therapeutic efficacy. Male fetuses developed non-malignant genital abnormality. Cancerogenesis due to medicine follow prolonged drug exposure, for example, months or years. The cancers develop most commonly over 5 years, but sometimes years after treatment has ceased. There is high incidence of secondary cancer in patients treated for primary cancer drug. The medical profession has a grave duty to refrain from all unnecessary prescribing for women of childbearing potential of drugs with say less than 10 years of widespread use behind them. It's not sufficient safeguard merely to ask a woman if she is or may be pregnant for. It's also necessary to consider the possibility that a woman who is not pregnant at the time of prescribing may become too while taking the drug. Testing of new drug on animals for reproductive effects has been mandatory since thalidomide disaster event, so the extrapolation of the finding to humans is uncertain. Impotence may occur with drug affecting autonomic sympathetic function. For example, many antihypersensitive spermatogenesis is reduced by a number of drugs, including sulfasalazine, mesalazine, cytotoxic anti-cancer drugs, and nitrofurans. There has been a global decline in sperm concentration and environmental cause. For example, chemical that possess osteogenic activity seems likely. Causation of birth defect due to abnormal sperm remain uncertain. Cross allergy within a group of drug is usual, for example, penicillin. When allergy to a particular drug is established, select the substitute from chemically different group. Patient with allergic disease, atopy, for example, eczema, are more likely to develop allergy to drug. The extent of cross-reaction with cephalosporin is highly controversial with penicillins. So, principal clinical manifestation and treatment. It can be urtical rashes, angioedema, and types 1 and type 3 allergic reaction. It's can be non-urtical rashes, types 1, types 2, types 4 allergic reaction, and disease of the lymphoid system, type 1 reaction. Anaphylactic shock, type 1 reaction, very quickly and very hardly. The following account combines advice from different countries with comment on the action of the drug used. Advice on the management of anaphylactic shock is altered periodically, and the reader should check the relevant different websites, and we will be to touch this topic next time. And I send this you can see this presentation, and you can write short note about drugs and doses for treatment, different allergic reaction of patients. It's from guideline. Mhm. So how drugs act and interact, how they enter the body, what happens to them inside the body, how their elimination from it, the effects of genetics, age, disease, drug action. These topics are important even if they are not prominent in the mind of the prescriber science understanding of them with rational decision taking. Knowledge of the requirements for success and the explanation for failure and for adverse events will enable the doctor to maximize the benefits and minimize the risk of drug therapy. Pharmacogenomic variability due to inherited influence, variability due to environmental and host influences, drug interaction outside the body at site of absorption, drug distribution directly on receptors during metabolism, during excretion. The practice of drug therapy entails more than remembering an apparently arbitrary list of action or indications. Scientific incompetence in the modern doctor is inexcusable and contrary to some assertion, scientific competence is wholly compatible with human approach. When a drug is administered, response occurs if second drug is given and the response to the first drug is altered. The drug-drug interaction is said to have occurred. Dramatic unintended interaction excite most notice, but they should not distract attention from the many intended interaction. There are the basis of rational polypharmacy, for example, multi-drug treatment of tuberculosis, naloxone for morphine overdose, for completeness alteration in drug action causes by diet, term drug-food interaction, and so by drug-herb interaction. The quantity of drug listed is any national formulary provides ample scope for possible alteration in the dispositing effect of the drug by another drug. But in practice, clinically important adverse drug-drug interaction become likely with drugs that have a step dose response groups and a small therapeutic index because small quantitative changes at the target site, for example, receptor or enzyme lead to substantial changes in effect, for example, digoxin or lithium. Next, drugs that are no enzyme inducers or inhibitors. Next, drugs that exhibit saturable metabolism zero order kinetics when small interference with kinetics may lead to large alteration of plasma concentration, for example, theophylline. Next, drugs that are used long-term Next, patients who have significantly impaired liver or kidney dysfunction. And next, the elderly patients. Listening or cognizant possible adverse drug-drug interaction now readily available in national formulation on compact disc or YouTube channel. We provide overview the pharmacological basis for wanted and unwanted effect, pharmacodynamic interaction. Both drug act on the target side of clinical effect, exerting synergism, antagonism. The drugs may act on the sum or different receptors or processes, mediating similar biological consequences. And pharmacokinetic interactions. Drug interacted from the target site to altered plasma and other tissue concentration shows that the amount of the drug at the target site of clinical effect is altered. For example, enzyme inducing by rifampicin reduces the plasma concentration of warfarin. Enzyme inhibition by ciprofloxacin increases the concentration of theophylline. And interaction may result in antagonism or synergism. Antagonism occurs when the action of one drug opposes that of another. The two drugs simply have opposite pharmacodynamic effects. For example, histamine and adrenaline, epinephrine on the bronch inhibit physiological or functional antagonism, or they compete reversibly for the some drug receptors. For example, benzodiazepines and flumazenil exhibit competitive antagonism. Synergism is of two types, summation, potential. And strictly, the term synergism applies only to the second condition, but it's now commonly applied to both. In broad term, it's useful to distinguish the drug-drug interaction that occur before drugs enter the body at important points during their disposition and metabolism, and all at receptor side. Intravenous fluids offer special scope for interaction. Drugs commonly are weak organic acids or bases produced as salt to improve their solubility. Bluntly, the mixing of solution of salt can result in instability which may or may not be visible in the solution. For example, precipitation. While specific sources of information available in manufacturer's package inserts and formulation issue of compatibility complex and layer within the professional competence of the hospital pharmacy, which should prepare drug addiction to infusion solutions in any situation involving unfamiliar drugs. Their help and advice should be those. And the complex environment of the gut provides opportunity for drugs to interfere with one another both directly and indirectly by altering gut physiologically. Usually the result is to impair absorption by direct chemical interaction in the gut. Antacids then contain aluminium and magnesium from soluble and non-absorbable complexes with tetracycline, iron, and prednisolone. Milk contains sufficient calcium to warfarin is avoidance as major article of diet is tetracycline. Cholestyramine interference with the absorption of levothyroxine, digoxin, some acid drugs, for example, warfarin. Separating the dosing of interaction drugs by at least 2 hours should largely avoid the problem. Altering gut motility, showing of gastric competing, for example, opioid analgesic, tricyclic antidepressants, may delay and reduce the absorption of other drugs. Purgatives reduce the time spent in the small intestine and give less opportunity for the absorption of poorly soluble substances such as adrenal, corticosteroidal, and digoxin. Altering gut flora, antimicrobial proteins, oral anticoagulants by reducing bacterial synthesis of vitamin K, usually only after antimicrobial are given orally in high dose, for example, treat Helicobacter pylori. And interaction other than in the gut. Hyaluronidase promotes dissipation of subcutaneous injection and vasoconstrictors, adrenaline, epinephrine, teliprizine, the absorption of local anesthetics, useful to prolong local anesthesia. The complex environment of the gut provides opportunity for drugs to interfere with one another both directly and indirectly by altering gut physiology. Usually the result is to impair absorption by direct chemical interaction in the gut. Antacids then contain aluminum and magnesium from insoluble and non-adsorbate complex with tetracycline, iron, separating the dosing of interaction drug by less than 2 hours should largely carrier media transport control processing such bioavailability passage into the central nervous system, hepatic uptake and entry into bile and renal tubular excretion. Inhibitors and inducers of drug transporters can profoundly influence the disposition of drug. The transporter MDR1 controls the entry of digoxin into cells. Quinidine, verapamil, cyclosporin inhibit the transporter and increase the plasma concentration of digoxin with potentially toxic effect. Probenecid inhibits the organic anion renal transporter, which decreases the renal clearance of penicillin, usefully prolonging its effect, but also that of methotrexate with danger of toxicity. Elucidation of the location and function of transport system will give the explanation for and allow the prediction of many mode of drug interaction. And during metabolism, enzyme induction and even more powerful enzyme inhibition, important source of drug-drug interaction. At receptor sites, there are numerous examples. Beneficial interaction occurs in overdose as with naloxone for morphine overdose opioid receptors, atropine for anticholinesterase, for example, insecticide position at acetylcholine receptors, phenethylamine for the monoamine oxidase inhibitor sympathogenic interaction, alpha adrenergic receptor. Unwanted reaction include the loss of the antihypertensive effect of beta blockers with common cold remedies containing ephedrine, phenyl propanolamine or phenylephrine, usually taken to the doctor. There are alpha adrenergic receptor agonist action is understated in the beta blocked patient. Many substances by virtue of this relatively high lipophilicity not only retain it at the active site of the enzyme but remain non-specifically specifically bound to the lipid endoplasmic reticulum membrane. In this state, they may induce microsomal enzymes, particularly after repeated use. Acutely, depending on the residual drug levels at the active site, they also may competitively inhibit the metabolism of simultaneously administered drug. Conversely, simulation administration of two or more drugs may result in impaired elimination of the most slowly metabolized drug and prolongation of potential of its pharmacological effects. Thank you for your attention. You can write your question on our command chat in Telegram.